Hello again, and welcome to another session of Cardiac Imaging Agora. In this session, we're going to talk about diagnosing a-TTR, and we'll talk about integrating clinical and imaging findings. I have the honor in this session to have my colleague and friend and one of our great trainees, Dr. Amit Goyal. Amit, in addition to being a super fellow here at the Cleveland Clinic, he's one of the co-founders of Cardi Nerds. If you haven't listened to Cardi Nerds, you're missing a lot. This is the website. It's a phenomenal job you guys have done over the past few months. Right now, it's a permanent staple for my weekend runs. So this is actually a beautiful podcast, and this is some of the stuff you guys have done over the past few months. When did you guys start doing this?
You know, Dr. Jaber, thank you for the wonderful introduction. This is a podcast that I do with Daniel Ambinder, Kareem Hamo, and Heather Kagan. We all trainees, we started this in December 23rd, and just here in less than 4 months, we've been able to had the pleasure of producing 30 episodes with a lot of support from our mentors like yourself. So thank you for the introduction.
Unbelievable. 30 episodes, all top notch. I enjoy it. It's very interactive, very funny. I feel really like when I'm listening to it, like I'm sitting at the bar somewhere having a beer with somebody and listening to this. It's just phenomenal. Thank you for that.
Thank you, Dr. Jaber.
I'm going to take you through this. So just you start this. This is one of your patients that you saw just a couple of days ago, being admitted to the hospital. And you
That's right. So, you know, just before we get started, I do want to congratulate you and Dr. Gemelli for creating this wonderful service, the Cardiac Imaging Agora. And more than congratulate you, I want to thank you, because in the COVID era, there's been such a hiatus in medical education. So you're really fulfilling such a great niche for us. So on that note, I'd love to get your take on this patient. It's a 74-year-old patient who presented with mild dyspnea and exertion and dizziness to the emergency room. He has a history of hypertension and hyperlipidemia. And at the time, he was on 4 antihypertensives, as well as statin and an aspirin. His EKG at the time, and again, this was 5 years ago, as you can see here, he's got a normal sinus rhythm with LVH and ST depressions laterally, perhaps from a strain pattern. Here's his chest x-ray on his initial presentation, not very remarkable. His cardiac biomarkers, troponin T, was elevated at 0.049 and 0.50, and so he proceeded to get a cardiac cath, which showed normal epicardial coronary arteries at the time, a proBNP of 211, normal CBC and renal function, and so he also had an echocardiogram at the time, and here you see his peristernal long axis, apical 4, apical 2 chamber. You know, perhaps he had some diastolic dysfunction at the time, but really not a very remarkable echocardiogram.
Yeah, it's very interesting. You know, this echocardiogram for me is just completely unremarkable. It's just normal systolic function, normal right ventricular function. I don't see anything remarkable here for a 75 years old person.
Unfortunately, since then, he's had multiple admissions for heart failure. And in April 2020, he presented to our hospital with worsening dyspnea. And interestingly, he was off all of his blood pressure medicines because of intervening hypotension that he had developed over the past 2 years. And so he was essentially cured of his hypertension. He only remained on low-dose furosemide and a statin.
So this is a couple of days ago when you admitted him, right?
That's correct. His chest x-ray shows diffuse infiltrates, probably from pulmonary edema. He had acute renal insufficiency. His troponins were elevated at 0.165 and 0.144. And you take a look at his troponin trend over these intervening days, and it's sort of stably elevated without a definitive rise in peak and a fall. His NT-proBNP was high at 2200. His EKG this time around was a little different. He has now rate-controlled atrial fibrillation with low voltage and Q waves in his anterior precordium.
Remarkable drop in, you know, the only time you see this if somebody developed emphysema over time. You can see it if somebody gained tremendous amount of weight, somebody with anasarca, right? These are the things that are going in my mind right now as far as a drop in voltage from here to here. So we'll go over that later.
And so, Dr. Jabber, here's this echocardiogram that we saw just yesterday. And, the interesting to note that despite his low voltage on his EKG, he's got pretty severe concentric LV hypertrophy, preserved systolic function. It looks like his left atrium is large, but we may have an apical view to take a look at it a little more. So in the apical fourth chamber, you see he's got biatrial enlargement, a thickened interatrial septum.
Yeah, it's very remarkable how small is the LV cavity. The atrium is probably the left atrial cavity is bigger than almost than his left ventricular cavity, and that remarkable thickening of the ventricle, despite that you said that his hypertension is cured. So we're not going in the right direction of curing hypertension. This is what you expect to see if you have somebody with, chronically untreated hypertension with secondary LVH.
Exactly. And so his tissue Doppler velocities were low. Looks like on the lateral it was 0.03 and medial is 0.03 as well. Mm-hmm. His Doppler through the mitral valve shows atrial fibrillation, and it looks like his strain pattern has reduced global longitudinal strain with apical sparing.
Oh, that's very interesting. So this is a remarkable change from the echo in 2015, right? And we have many things here pointing to towards the development of a newer disease or newer entity.
Absolutely. So overall in his picture, in the past 5 years, he's developed diastolic heart failure with LVH, decreasing need for antihypertensive medicine, so essentially a pseudo cure, atrial fibrillation, low voltage on ECG despite the significant degree of LVH, a chronic troponin elevation, and a classic strain pattern, which is typical for amyloid heart disease.
So this is what alerted you to order the test. So what did you do when you saw him after that? What test did you think of?
Yeah, I think in this scenario, thinking about the cause of infiltrative heart disease, specifically with a strain pattern looking like amyloid, we decided to proceed with both a lab test as well as a nuclear imaging test. And so we sent him for a PYP scan.
So this is when I got involved with it, and thank you for involving me. This is an interesting case. This is a common occurrence right now, especially that we know more about this disease, and we have a easy, non-invasive way of diagnosing it, whether it's by the suspicion side, which is the EKG, the blood test that you went over, plus the technetium pyrophosphate scan, which made non-invasive, almost a non-invasive biopsy for this pattern. So while reviewing the images, I just want to point the viewers to this document that's extremely important and essential reference, I think, in reading these scans. It's actually the clutter of all the data and all the graphs and survival and mortality and all the stuff is taken out, and it's made very easy as a practical, easy reference to do these images and interpret them. So and every time you decide to do an imaging study, whether it's nuclear, whether it's CT, whether it's echo, always put in your mind what are the steps you want to do to review these images. Whatever steps you choose, it doesn't matter as long as you follow all these steps, because otherwise you're going to end up missing something, you're going to end up not reporting something, you're going to end up with a report that the referring physician doesn't understand. So this is the list in my mind that I put when I review any of these technetium pyrophosphate scans. And we'll go through them one by one. So first, I look at the planar images, and these are the images. If you don't have a SPECT camera and you're doing these on a planar camera, you can actually acquire these images. On a planar camera, the image will not be rotating. It will be just planar, like an AP view on a chest X-ray. And you can see here on top, you can see the heart. This is actually a nice psychedelic thing. So if you're listening to Bob Marley and watching this, you will be seeing this. Doing other things too.
Later today.
Yeah, but on top is just what you should see, which is basically we focus on the heart here. And in a normal patient, you shouldn't have any technetium pyrophosphate uptake in the heart. And you can see here, there is immediately, you can see this is a bright spot, a light bulb is turned on in the heart. Contralaterally, in the other side of the chest, there is nothing. So this is the first step. So right away in my mind, I'm thinking this is a positive scan.
I see that now that you pointed
positive?
out.
Sorry.
I see it now that you pointed out.
Yeah. So that's the easy way to look at it. So from this point on, all the other stuff is important for formulating a meaningful report, not to just treat it almost like a pregnancy test. Is it positive or negative? Now we have gradations, we have reasons to do that, and especially as the disease evolves, as we have treatment for this disease, because we don't know how this intensity of uptake changes with disease progression. We don't know how it changes with disease regression if we're treating it. So these things have not been answered. So if you're starting to do this for a living or to help your patients, it's important that you do it in the right way so you can have actually a database to follow up these patients in the future and figure out if treatment is working or not, or does this treatment affect the number of or the intensity of the uptake. We don't know that.
It's very interesting.
So the next thing we look at is this what we call semi-quantitative imaging. This is basically your eyes looking at the camera at the image and thinking, how much uptake is there here? Is there no uptake? This is 0, done. If the uptake is 3, what is 3 uptake? Is basically if you have uptake more than the ribs in the heart. And here, if you look at this, Amit, I think you would agree with me that this is not greater than the ribs. This is probably as much as the ribs. So it's not, it's just, there's just some art in doing this. The more you read of these, the better. But if you compare it to the ribs, this is probably about as equal to the ribs as you see here in these images. And probably this is a grade 2.
Great.
Now, probably tomorrow morning, I change the intensity, I grade 3. I don't think it's going to change whether I call this positive or negative, but just for a semi-quantitative thing, this works pretty well to compare it to the ribs. Is that reasonable?
I think that makes a lot of sense.
Okay. So then we go to some quantification of that uptake. So this is the classic paper looking at that and basically establishing this threshold of calling something a-TTR positive or negative. So basically you put an area of interest over the heart and you take the same area of interest and put it over the contralateral chest right here. And basically what the software will do for you, calculate the number of counts in this area over this area. And what you'll end up with is what you see here, a heart to contralateral lung ratio. And in this instance, it was 1.48. In our lab, we have established anything more than 1.25 at 3 hours is consistent with a-TTR. Now, this might be different if you're doing it at 1 hour, but safely you can say that's a reasonable cutoff. And most of the data reported in the literature ranges around 1.3 all the way to 1.6, but this is pulling data from multiple centers, multiple times at imaging the patient. So some centers image the patient within an hour, some centers image within 3 hours. So there is some variability there, but if you take 1.25 at 3 hours, which we do for all our patients, you will end up probably with a very high sensitivity and specificity and a very high 90% plus. So this is how we do this semi-quantitatively.
So now, for our patient, this test is unequivocally positive at this point.
Yeah, so from this point on, we're done. Fortunately, here we do SPECT on all these patients. So we don't only stop at the planar images I showed you. So we go to the SPECT images. What SPECT means is we have a CT scan, basically a scout CT done, and we try to superimpose the perfusion images traditionally by SPECT, but here we're taking the amyloid uptake images over that. And you can see here where the uptake is. I think it is extremely helpful to do that for a couple of reasons. First, you can localize the uptake in the heart where it is. Now you can see here it's in the left ventricle. Another example in this video series, and you'll see it when you're rotating in the lab this month, you'll see some examples where you have RV uptake. Sometimes you have more RV uptake than LV uptake. Sometimes you have uptake in the interatrial septum, and that's what we see on echo as lipomatous hypertrophy. Sometimes you see it in the walls of the atria, and that's sometimes we see that very often actually in patients in atrial fibrillation. So that's something we're studying right now. And the other thing you will see sometimes that apical sparing pattern that you see by echo, you will see no uptake in the apex often in these patients.
That's very
cool. The other important thing about looking at these SPECT images is to make sure that the uptake is not in the cavity. If you get a patient towards the end stage part of their amyloid disease, let's say patients in shock or whatever, sometimes the tracer does not clear the ventricle. and the tracer ends up being just in the in the LV cavity, but not in the walls.
Oh, that's
so
interesting.
if you look at the planar images, you look like you have an uptake, but actually it's not in the walls. So that's actually a pseudo-positive scan. And it can have ramifications for treatment and all these things. So you have to be sure that you don't have that. Another thing we look at, we find pleural effusions, as you see in this case, and we saw that on a chest X-ray. And because we're dealing with a lot of patients who are elderly with amyloid, very often, actually, it's not uncommon for us to find extra cardiac lesions like cancers, nodules in the lungs, aortic aneurysms, stuff like that. So it's important to look at these images. And that's, we're fortunate because we do SPECT on all these patients. And that's how the SPECT images look like. It's like a traditional perfusion image. We go over the image, we make sure we center it over the heart. The quality of the image is not as good as a regular SPECT because you have patchy uptake, not diffuse uptake. Sometimes we see diffuse uptake, but in general it's patchy. And then we go here and we look at them in this way. So that's what we have right here. This is the heart. We're looking at it here. Again, the uptake is in the LV walls, and then it's not in the cavity, which is very important. And in this instance, we have minimal RV uptake. So RV uptake has been shown from studies from our center and many other places to be, to correlate with the poor prognosis, because that's a reflection also of pulmonary hypertension and other things. Then we look at the the CT without the technetium pyrophosphate images on it, so just the transmission image, what we call. And we look at the things we talked about earlier, the pleural effusion, the calcification of the aorta, the calcifications right here, coronary calcification, aortic calcification. Often these patients have concomitant aortic stenosis plus TTR amyloidosis. You can see the extent of calcification here. In this instance, we didn't have that because we have the echo, we saw that, but sometimes we get this as the first image and we recommend an echo on these patients. And that's when you find these low flow, low gradient aortic stenosis patients. Now, all this stuff is fun and beautiful for you and I to talk about, but how do we translate this into a meaningful report? We report the demographics of this population, what methods we use, what tracer we use, what time we injected, at what time interval we imaged, so we have consistency. So we always image either at 1 hour, depends what you want to do in your lab, or at 3 hours. In our lab, we've switched to 3 hours now routinely. This is at 180 minutes. Height and weight, all these things, and whether we have a biopsy on these patients. So this is becoming very rare right now, but in the past, we used to start with the biopsy and then move to this when we were learning about this, but now biopsy is really rare. But it's important to know that. Then what we just talked about, we just put it in a nice template, so we can actually interrogate this template for fellows like you in 2-3 years. You want to do research and figure out what's going on with these patients. How good are we at sensitivity, specificity, correlation with mortality. We have this in a template format where we can grab it and look at it quickly without having to go through dictated notes and interrogation of epic and other things. And we use the semi-quantitative scale again with the heart to contralateral ratio right here that's reported. We report the pattern of uptake. In this instance, we didn't call it diffuse, we call it focal. Sometimes we disagree, we call it focal and diffuse. And if we just see it only in the blood pool, we call that persistent blood pool, and we don't call the image positive. So this is probably most of the stuff that we read from the scan. Here we not comment about the pleural effusion and some of the prior findings. So this is, we have the conclusion has to be definitive. We don't have a wishy-washy conclusion. Very rarely we have those, and those are patients that either are very early in the disease that we're catching right now because of the increased awareness of it or because of screening of family members, or they tend to be AL amyloidosis. These are the equivocal patients, but they're not TTR. TTR in general ends up being very positive. So this is basically, these are the elements of the report. Basically, we follow what was recommended by the American Society of Nuclear Cardiology. Actually, we developed this before the society came out with these guidelines a couple of years ago. And we've been doing it now routinely in the fashion I just showed you since 2011. So we have about 9 years of data and reporting in that format. And fortunately, the American Society of Nuclear Cardiology agreed with the way we read them. And we didn't have to change much after they came up with this. I just want to make sure that you and I, whenever we read these, That's what we look at. We review not only the images we're looking at. We don't live in silos. We look at the chest X-ray, as we just did. We look at the EKG. You can see here what we saw, the medications, the labs, the echo over time if available. So that's basically how we do it, how the sausage is made.
This is very helpful. You know, we talked about cardiac amyloid on Cardi Nerds, but it's so nice to see exactly how you approach the PYP scan. And so just to summarize, after we made the clinical suspicion, you send the patient for the PYP scan. You start off with a qualitative assessment. You move on to the semi-quantitative assessment with a four scale grading system. You have the quantitative assessment with the heart to contralateral side. And then you look at the reconstructed images to look at the blood pool itself and the distribution of the uptake to get the overall picture of the scan.
That's exactly right. That's exactly right. And let's always keep in mind these caveats that I keep in mind every time I'm reading a scan, because no matter what you do in life, including images or cath or anything you want to do as a cardiologist, just keep in mind that nothing is perfect. Nothing has ever been perfect. And because of that, we keep in mind these things. We talked about them earlier a few minutes ago. The negative or mildly positive slide does not exclude AL amyloid. Mm-hmm. Keep that in mind. And in all these patients, as you have done properly in this instance, you ordered the serology test. Unfortunately, this is a fresh case. We don't have the serology test results yet. You just ordered them. And this is the type of test we order at our center for all patients, even when we think about technetium pyrophosphate scanning. So technetium pyrophosphate scanning plus the serology to do that.
I'm smiling because I remember Dr. Paul Kremer once said that missing AL amyloid is like missing a STEMI. So I think this is...
Yeah, it is catastrophic. You know, in the past, we used to think about missing a-TTR as, okay, what's the big deal? Because there was no treatment. The pattern is going to go down that way, and the patient is going to follow some poor prognosis. But as you said, AL is a disease that requires acute management. Mm-hmm. The sooner you get these patients to therapy, the better. So 100%. It should never, ever be missed. So you should never stop, even as an imager, even if you're not involved in clinical care. You should actually convey that message in either a phone call or somewhere in your report, that just because I read this as negative, it does not exclude the AL, because right. Not everybody is as sophisticated in knowledge of differentiating amyloid between AL and TTR. And in this instance, we found many cases actually. We have a series of about 6 to 7 patients, even in the past year and a half, 2 years, of patients having both, because this is a population that is right. prone to have TTR because of age, senile amyloidosis, and also because of their age, they're actually at risk of having AL. So we've 100%. Treated patients for both at the same time. So this is something not to be missed. Thank you for raising right. that point.
And I think this is such a great talk, because with the advent of non-invasive imaging, we're realizing that TTR is not as rare as once we perceived it to be. So, it's important to not miss them with all these clinical features this patient had, like the severe LVH, curing of the hypertension, low voltage, and all these things. So,
thank you, Amit. This is a great case you got me involved in. I was looking for an amyloid case, and you came up with this very quickly. Thank you so much for making a diagnosis for a patient after 5 years of presenting to the hospital with heart failure. And that's actually not unusual. If you take time to diagnosis for a-TTR, maybe it's changing right now, but at least in the reported literature is actually anywhere between 18 months to 24 months before diagnosis is made, even at major centers. Hopefully, we don't make this mistake in the modern era anymore, and we get these patients to therapy as soon as we can. Thank you so much, and I'm really enjoyed this. Hopefully, we'll do a couple of these sessions this month since you're in the nuclear lab. Thank you.
Well, thank you for having me, Dr. Jabra. I certainly will love to come back. Appreciate it.
Bye-bye.